Hi. This presentation will be an attempt to summarize the current evidence revolving around oxygenation strategies for COVID patients in respiratory failure. In adults with COVID-19, it is suggested to start supplemental oxygen if the peripheral oxygen saturation is lower than 92% and recommended if the SpO2 is lower than 90%. Also, in adults with COVID-19 and acute hypoxemic respiratory failure on oxygen, it is recommended that the SpO2 is to be maintained no higher than 96%. Now, these two magic numbers come from research aimed at identifying the best target of oxygenation in relation to mortality in patients with ARDS. A randomized controlled trial published a couple of weeks ago in the New England Journal of Medicine was stopped for futility and possible harm and showed that a conservative oxygenation strategy with a peripheral oxygen saturation target of 88 to 92% was associated with an increased mortality at 90 days. On the other hand, a 2018 systematic review and meta-analysis published in The Lancet showed that a liberal oxygen strategy with a peripheral oxygen saturation target above 96 was also associated with increased risk of hospital mortality. So in summary, no less than 92 and no more than 96. Easy to remember. Now obviously, you can try to achieve this target by using your normal face mask, Venturi mask, or non-rebreather oxygen mask. If the patient is still in acute hypoxemic respiratory failure despite conventional oxygen therapy, the question is, do we go with non-invasive ventilation or with high-flow nasal cannula? Let's explore non-invasive ventilation first. In adults presenting with hypoxic respiratory failure from COVID-19, there is no direct evidence to support the use of NIV. We know that NIV is beneficial in cardiogenic pulmonary edema, acute exacerbation of COPD, and post-extubation, but its use in ARDS is still controversial. In ARDS, NIV has a high failure rate, and its use could delay invasive mechanical ventilation and expose the patient to prolonged volotrauma due to variable tidal volumes, with an overall increase in mortality. In addition, NIV is an aerosol-generating procedure that can increase the risk of transmission of disease to healthcare workers. Some authors have suggested delivering NIV with a helmet instead of a face mask. The rationale behind this suggestion is to be found in a single-center randomized controlled trial that showed decreased intubation and improved mortality using NIV helmet in ARDS. Also, NIV by helmet has been shown to reduce exhaled air dispersion, therefore reducing the potential of infection among healthcare workers. This, however, has not been demonstrated scientifically. Let's now have a look at high-flow nasal cannula. We know that high-flow nasal cannula reduces intubation compared with conventional oxygen, but does not affect the risk of death or ICU length of stay. The reduction in the need for intubation, however, is particularly important in the context of COVID-19, where resources such as critical care beds and ventilators may become limited. Different from NIV, high-flow nasal cannula does not appear to have an increased risk in spreading the disease. In studies evaluating bacterial environment contamination, high-flow nasal cannula presented a contamination risk similar to that of conventional oxygen. In the SARS epidemic, healthcare workers exposed to high-flow nasal cannula were not at increased risk of developing disease. Some authors advised against the use of high-flow nasal cannula in patients with COVID-19 due to the fear of disease transmission. This claim, however, is not supported by any scientific evidence. In summary, for adults with COVID-19 and acute hypoxemic respiratory failure, it is suggested to use high-flow nasal cannula over NIV whenever possible. When resources become stretched, however, there may be insufficient ability to provide invasive ventilation, and even a moderate chance of success with NIV may justify its use. In this case, it is important to remind that NIV is an aerosol generating procedure and should be used with full PPEs, ideally in an environment with negative pressure air exchange. Now, if the COVID patient does not respond quickly to high-flow nasal cannula, it is recommended to intubate early rather than waiting too long. An early, aggressive strategy has been shown beneficial in terms of patient survival. In mechanically ventilated adults with COVID-19 and ARDS, it is recommended to use the so-called protective ventilation approach. There are 7 key concepts that you must remember while ventilating an ARDS. 1. Use a tidal volume of 4 to 8 milliliters per kilogram of predicted body weight. That is the predicted weight using a formula that accounts for sex and height. This tidal volume could be obviously achieved either by volume or pressure control ventilation. Now, I know that pressure control has some physiological advantages, but for the sake of safety and simplicity, I would suggest sticking with the volume control modality. Number 2. Use high PEEP. And by high PEEP, I mean high PEEP in the range of 12 to 16 centimeters of water. There is no magic number, obviously, and you should be able to set the best PEEP for each individual patient at different times, always considering the strain on the right heart and the static compliance of the lungs. I made a video on setting the best PEEP, and I'll place a link in the description. Number 3. Perform recruitment maneuvers. These will help identifying the best PEEP. Be always ready to insert a chest drain in case of pneumothorax. Also a link in the description for that. Number 4. Maintain the plateau pressure below 30 centimeters of water. Now here, I need to clarify what plateau pressure is and how to visualize it on the monitor. Let's have a look at the pressure curve over time during volume control ventilation. The peak pressure here is the total pressure needed to push a volume of gas into the lungs, and is composed of pressures resulting from inspiratory flow resistance, also called resistive pressure, the elastic recoil of the lung and chest wall, known as elastic pressure, and the PEEP. Resistive pressure is the product of circuit resistance and airflow. Resistance to airflow occurs in the ventilator circuit, the endotracheal tube, and in the patient's main airways. Elastic pressure is the product of the elastic recoil of the lungs and chest wall, or elastance, and the volume of gas delivered. For a given volume, elastic pressure is increased by increased lung stiffness, as in pulmonary fibrosis, or restricted excursion of the chest wall or diaphragm, for example intense ascites or massive obesity. Now, because elastance is the inverse of compliance, high elastance is the same as low compliance. So if you have a high elastic pressure or a high plateau pressure, your compliance will be low. To be able to visualize this plateau pressure during volume control ventilation, you must set an inspiratory pose. An inspiratory pose of 0.3 is adequate. Once you do so, you will notice a change in the shape of the curve. This is due to the fall of the resistive component of the total pressure due to the interruption of airflow. The plateau pressure will be visualized on the monitor screen, and you'll need to keep that below 30 centimeters of water. Number 5. Maintain a driving pressure below 14 centimeters of water. The driving pressure is simply the difference between the plateau pressure and the PEEP. Number 6. Maintain an even or slightly negative fluid balance. A conservative fluid management in patients with ARDS has been associated with increased ventilator-free days and decreased ICU length of stay. Number 7. Consider early prone ventilation. This has been shown to reduce mortality in ARDS and should be maintained for at least 12 and possibly for 16 hours, taking however into account the increased risk of pressure sores and endotracheal tube obstruction. So to recap, use low tidal volumes, high PEEP, perform recruitment maneuvers, maintain a plateau pressure below 30 and a driving pressure below 14 centimeters of water, adopt a conservative fluid management, and consider early prone ventilation. Last brief consideration about medication we could use to help oxygenating the patient. For inhaled vasodilators such as nitric oxide and prostacyclin, avoid using these drugs routinely due to the increased risk of kidney injury. Consider these options as a last resort rescue therapy when even prone positioning has failed and venovenous ECMO is not an option. Neuromuscular blocking agents, we should try to avoid them to prevent diaphragm atrophy. However, should we need them to facilitate protective ventilation, it is suggested a bolus approach. Continuous infusion of neuromuscular blocking agents is to be reserved only for prone positioning. So in conclusion, keep an oxygen saturation between 92 and 96%, prefer high-flow nasal cannula over NIV whenever possible, and remember, if you use NIV, that is an aerosol generating procedure, therefore you need to be fully protected and you should be ideally working in a negative pressure environment. And if you're mechanically ventilating the patient in ARDS, remember to adopt the protective ventilation approach. Thank you very much and see you next time.